So welcome everybody, and hopefully people have found a way to ask questions. I'm happy to have questions come up as they go along. I will perhaps, Jim, to be sure, I will stop every so often and see if there are questions so that you can unmute folks in case they're having trouble asking those questions. The webinar format is a little odd. I tend to like a kind of interactive talk when I speak with folks, and so this is a little bit alienating, but we'll make the best of it. So as Jim said, this was a talk that that we gave at the Parents Conference in Denver a while ago. I forget even now when it was. And there were a number of questions that arose from the audience, so hopefully folks will feel free to ask questions as we go here. So we're going to talk about really testosterone therapy in children and adults. It's really a seamless discussion about use of testosterone in boys and men with Klinefelter syndrome. And I'll show you a few, what's happening here? And a few Rocky Mountain flowers as we go to keep your attention in case it starts to drift. That's weird. There we go. So we're going to talk about testosterone deficiency, which is called hypogonadism, or a decreased gonad function. And in order to understand testosterone therapy, I generally think it's important for folks to understand sufficient background so that the choices and options make more sense. So we'll talk about the physiology and cause of hypogonadism, and that's actually going to require us to talk about normal gonad, normal testicular physiology in males, and how puberty develops, etc. Then we'll talk about potential benefits and disadvantages of testosterone therapy. We'll talk about how to approach timing of testosterone therapy, and we'll spend some time talking about treatment options. We'll also talk about treatment of the small penis. We'll talk some about gynecomastia. We'll talk about other hormonal abnormalities that are more prevalent in individuals with Klinefelters and similar variants, and then presumably we'll have some time to talk about whatever else people want to talk about. Okay, so in order to understand testicular function, we need to really start in the brain with the pituitary, and you should be able to see my arrow. So the pituitary is a hormone gland that's located just behind the eyes. It is actually, people sometimes refer to it as the master gland. I think that's a little bit overly simplified. In fact, the pituitary is more or less a warehouse that stores hormones of various kinds, but the real decision-making, the real regulation occurs in the base of the brain adjacent to the pituitary, called the hypothalamus. And the hypothalamus is responsible for integrating all the various signals coming from the central nervous system as well as from the rest of the body to tell the pituitary which hormones to make, how much, and how often. So the pituitary produces a number of hormones. It makes prolactin, which is responsible in girls for breast maturation and milk production. It makes growth hormone, which produces increased height as well as development of bones and muscles necessary for healthy development. Pituitary makes a hormone called thyroid stimulating hormone, or TSH, whose job is to promote production of thyroid hormone from the thyroid gland, and we'll come back to thyroid hormone at the end of the talk. pituitary also makes a hormone called ACTH. It's a long name. You don't need to know what it stands for, really. ACTH's responsibility is to regulate the adrenal cortex, which is a gland sitting above the kidney, to produce the stress hormone cortisol. And then finally, and what we'll focus on the most, are two hormones that are referred together as the gonadotropins. They are luteinizing hormone, or LH, and follicle stimulating hormone, or FSH. We won't ever refer to them again with their full names. Everybody just calls them LH and FSH. Together, these are called the gonadotropins, and they're responsible for stimulation of the gonads to make both sex steroids, in males testosterone, in females estrogen and progesterone, as well as production of gametes, or sex cells, such as sperm and eggs. And so responsible then for both sexual characteristics as well as reproduction. Now, if we look more carefully at the gonadotropins, we actually don't need that slide. We need this slide. What we find is that we can piece this apart a bit more. So, as I said, the hypothalamus is responsible for essentially regulating the pituitary and telling the pituitary when to make hormones, how much hormones to make, etc. So the hormone that, or the signal that comes from the hypothalamus that's responsible for regulation of LH and FSH is another hormone called GnRH, or gonadotropin releasing hormone. And I'm raising that here because we'll look at this a bit more carefully in a minute. Now, GnRH regulates both LH and FSH, but we can tease apart the actions of LH and FSH a bit. So GnRH stimulates the production of LH, and LH then is transported to the testis through the blood and is responsible for stimulation of the production of testosterone from the testis. When testosterone is produced, it then travels back to the pituitary and suppresses the production of LH. Now, one interesting thing about this is that the action of testosterone to suppress LH is actually caused by estrogen that is made from testosterone within the pituitary. So the action of testosterone to suppress LH production is actually caused by locally formed estrogen from that testosterone in the pituitary gland. And I bring that up because that will become somewhat important later on in the talk. So, in summary here, LH's job is primarily to get the testosterone to make get the testis to make testosterone. When there's enough testosterone made, this feeds back to shut down luteinizing hormone production. Now, on the other side, GnRH also stimulates FSH, and again, FSH travels to the testis, but FSH's job is primarily to produce sperm. And when sperm are being produced, there is production of another hormone within the same cells that make sperm called inhibin that then goes back to shut off FSH. What that means is that in the absence of sperm production, there will not be suppression of FSH through inhibin because inhibin is not being made. And FSH then will continue to be driven by GnRH. Similarly, if there is no testosterone production, GnRH will continue to drive LH, but the production of LH won't be suppressed by the appearance of that hormone. So let me take a break there and see if there are any questions up to that point. Anybody?
Unmuted.
I have unmuted everyone, but I'm not sure. Yeah, I muted it all. If someone has a question, I'm going to open the mics again very quickly, and before that feedback starts, identify yourself, and I can mute all the others and open yours. So mics are opening now, and that's all of them. Does anyone have any questions? All right, I believe everyone is connected, paying attention, and no questions. Okay, Dr. Zeittler, when I do this mute and unmute thing, it
delays.
So I'm going to selectively mute everybody, and we can proceed.
We okay now?
Yes.
Okay, so another thing that we need to talk about when we talk about development of testicle function and testosterone production, and this is actually quite important when it comes to discussion about appropriate timing for initiation of testosterone therapy. So we need to take a look at this particular graph, and what this is showing is testosterone production on this axis. So as the line goes up, testosterone production is increasing, and the bottom shows different time points. So here's gestation. This is the first year of life, then up to 10 years, and then puberty, and then over time. And what we're seeing here in the black is testosterone production. And then the reality is that you can overlay this with both LH and FSH, more or less. So what we see is that, in fact, during development in a male, there is production of testosterone in the fetus, and that makes sense because that's responsible for the development of the penis, the scrotum, and the other external male genitalia. In the absence of testosterone, the penis would not form properly, and that's how you get a girl. So this is produced, and this is actually produced under the influence of hormones from the placenta. Late in gestation, this is then turned back off again, so that by the end of gestation, there is not very much testosterone being produced. Then, very rapidly, and the scale is off here, but very rapidly, there is an increase in testosterone production, so that by the end of the first week of life, testosterone production in a young boy is as high as it is in mid-puberty, as you can see comparing here. And, you know, 50% or so of that you'd expect in an adult male. So there's quite a bit of testosterone production in a boy at 1 month, at 1 week of age. It then falls, rises again at 1 month, which you don't see in this simplified cartoon, and then over the first year of life falls back again and is now suppressed. And again, as I said, you'll see the same pattern with the gonadotropins LH and FSH. So this is being driven by activation of the child's pituitary gland. The system appears to get shut off after a month of life, so that it's completely shut off between about 6 months really and 10 years in a boy, and no one has any clue currently how that occurs. No one has any clue how this occurs. But this production of testosterone and LH and FSH is extremely low during this period. Then, as puberty begins, LH and FSH begin to be made. Whatever that suppression is slowly removed, and testosterone begins to rise into adulthood. And this is a pretty steady rise that occurs through puberty, reaching adult amounts and then staying relatively steady until, well, this says 50 or 60. It's probably even younger than that, but we won't discuss that problem. And then sperm production begins a bit after the appearance of testosterone. So if we were to summarize that, what we see then is withdrawal of central nervous system inhibition. This then turns into the beginning of secretion of this hypothalamic hormone, GnRH, and it needs to be secreted in pulses in order to work. So pulsatile GnRH secretion begins. That then leads to pulsatile secretion of LH and FSH, and again, the occurrence of pulsatile secretion is important for how those hormones work. That leads to stimulation of the testes, increased sex steroids, development of secondary sexual characteristics, and subsequently production of sperm. To summarize what we've talked about then, we can see this as multiple stages. The axis is functional at birth. LH, FSH, and testosterone levels are similar to those in young adults. The axis then becomes quiet during childhood, and this is called latency. The mechanism of this suppression is unknown, but during this time, LH, FSH, and testosterone are very low. The axis slowly begins to activate at puberty. LH rises initially at night, and over time these pulses of LH become larger and more frequent. And the way that this system reactivates is currently still unknown. In a graphic form, what we see is that during pre-puberty, it looks like there's no LH being made. If you use a very sensitive assay, you can actually pick up some LH production that's occurring. In early puberty, you begin to see more pulsatile LH production. This increases both in frequency, in order. These spikes become clearer, and by the time you get into late puberty and adulthood, you get very distinct, rapid spikes of LH production. Questions up to this point? Jim, are you there?
Yes, I'm unmuting mics.
Okay.
Any questions, anyone? Okay, no questions.
Okay.
Muted.
Okay, so that's the background on how the system works. Now what we're going to do is talk a bit about the sort of development of puberty, the signs of puberty that occur. Now, the best true sign of puberty in a boy is the occurrence of testicular enlargement. As I told you, what starts first in puberty is production of GnRH, followed by production of LH and FSH. FSH begins to stimulate the testes to make more germ cells. The size of the testis is completely dependent on the production of those germ cells. So the first sign of puberty in a boy is testicular enlargement. That's something that we measure using beads, which you may have seen if you have a child who's been evaluated by a pediatric endocrinologist. On average, this occurs at about 11.8 years. Pubic hair generally occurs a little bit after that, although there are circumstances which it will occur earlier, and we'll talk about those in a moment. This occurs on average at 12 years. The penis begins to enlarge at 13 years. Growth acceleration occurs relatively late in puberty in boys, with an average of about 14 years in the latter half of puberty. Now, there is another process that's called Adrenal Archy that can occur at the same time or a bit earlier than puberty, and this is an increase of male hormones or androgen production from the adrenal gland, this hormone gland that sits above the kidney. And there's three hormones that are made in the adrenal gland. They're called DHEA, DHEA sulfate, and androstenedione. That doesn't matter much. This usually occurs at the same time as puberty, but not always, and it can occur a bit earlier. And the typical characteristics of Adrenal Archy are acne, oily skin, the production of axillary hair, odor, and a small amount of pubic hair without any testicular enlargement. So in boys where this is occurring and the testes haven't begun to enlarge, this may be due to Adrenal Archy, which is separate but usually occurs at the same time as puberty. Again, the feature of that is that there's no testicular enlargement. It may be difficult in Klinefelters and related variants to tell this because of decreased testicular enlargement, though most boys will actually have some testicular enlargement at puberty, and the early signs of puberty are usually present. Pediatric endocrinologists, we use Tanner staging to talk about the amount of pubic hair that's present. It's actually relatively simple, but it's pretty subjective. Tanner 1 is no pubic hair. Tanner 2 is a little bit of pubic hair. You can't see very well here. I generally say that if you can still count them, it's Tanner 2. Tanner 3 is more than that, but not countable. However, not fully filling the pubic area. Tanner 4 is filling the pubic area, but not extending onto the thighs or abdomen. And then Tanner 5 is showing up on the thighs and abdomen. I apologize for that ringing phone. As I said, testicular enlargement will occur at a size of testicular enlargement will occur first. If it's greater than 3 mLs, we consider that to be puberty. And you'll see pediatric endocrinologists using these beads. These little blue ones are prepubertal, so that's 3 mLs. And then larger, this is 4 mLs. Anything larger than that is considered to be pubertal. And then this can be used to track change in size of testes as boys develop. This is a little slide that shows average age of development of pubic hair. So this line is the average. This is the fifth to the 95th percentile. So this is Tanner stage 2, average at about a little over 12. Tanner stage 3, average of a little less than 14. Tanner stage 4, about 14.5, and Tanner stage 5, somewhere between 15 and 16 years of age on average. The growth spurt will generally occur in this region in boys, generally at a testicular size of about 12 to 15, which is right here. Okay. Questions?
Unmuting now. Any questions, anyone?
I'm muted.
Oh, that's bad.
Any questions?
Okay.
Unmuted. Muted.
Am I back on?
Yes.
Okay. So let's talk now about hypergonadism and Klinefelter syndrome and related variants. So what we see in Klinefelter syndrome is primary testicular failure. And what that means is that it's the testis itself that is failing. The central hormones responsible for the onset of puberty are normal, but the testis itself is abnormal and is unable to respond appropriately to LH and FSH. So what do we mean? So here's a picture of a normal testis, and what you will see in a normal testis is these, and this is in cross-section, so these are like tubes that are being cut in cross-section, and you're seeing a cross-section of that like you're looking at a tree trunk. What you're seeing is the cells that are producing the sperm. So these are Sertoli cells, and they are producing sperm, and as the sperm move out towards the center, they mature progressively, so that mature sperm are then released into the middle, which is really the center of this tube, and then travel down and are collected for ejaculation. In between these tubes are what are called Leydig cells that are responsible for testosterone production. This is a higher power, and you can actually see these sperm being produced. So here's mature sperm in the center of that tube as they develop from the germ cells, spermatocytes, progressively maturing to the point of being mature cells. This whole thing is called a seminiferous tubule, and these are coiled around each other so that you have long lengths of tubule in the testis. And again, the Leydig cells here between the seminiferous tubules responsible for testosterone production. So really the cells responsible for testosterone production take up very, very little space in the testis relative to those cells responsible for sperm production. That is why ultimately, well, I'll show you in a second. So here's a Klinefelter testis. Now, this is disorienting because it looks like you have very large tubules, but in fact, this is not the tubule. This are the tubules. So you see these tubules are lacking in organization. They're described by the term hyalinization. The organization, the cellular organization of the tubules has been replaced by just disordered protein deposition. Here's a little bit of a tubule left. You see some cells around that tubule, but it's beginning to hyalinize. Here's completely hyalinized tubules. A lot of connective tissue that's just disorganized connective tissue in here. And all of this is actually sort of Leydig cells. So that area that you would see in here has become this, and it looks like there's a lot of Leydig cells, but basically it's because you've lost everything else. And this is essentially a sort of a higher power. So what you see in a Klinefelter testis then is loss of the tubules, loss of the cells necessary for making sperm, but for the most part retention of the cells required for production of testosterone. And this is why in many of the boys, testosterone production will be relatively retained while the testis size is very small and sperm production is diminished. So now we need to go back to what we talked about before. Remember that between the ages of 1 and about 10, the pituitary is not trying to do anything. It's not attempting to make the testis work. It's not making LH and FSH. But once pituitary puberty starts, the pituitary begins to attempt to drive response from the testis. But sperm cell production is abnormal, and so therefore there is no feedback and FSH rises. Testosterone production is abnormal. And again, because there is no feedback, LH rises, and therefore you get what we call HyperGonadtropic hypogonadism. What that means is hypogonadism, decreased gonad function, but hypergonadotropic, there is an increase in the gonadotropins. So it's low testosterone, poor gonad function in the presence of high LH and FSH. But remember, LH and FSH won't be elevated prior to puberty because the pituitary is not trying to make anything happen. Now, how would you know when you'd expect that? When would you expect puberty to occur? And this is how we use something called a bone age. A bone age is a means to determine the degree of the development. Now, we know that boys develop at different rates. At the age of 13, some boys still look like they're 9, and other boys are just about ready to shave. That's a normal spectrum of development. We need some way to have a sense of where in the process the kid's body is intending to be. And so bone age is a means to determine the degree of development. Puberty will generally start when the bone age is 12 in boys. And I'll show you what I mean by bone age in a moment. Bone age is a better predictor of puberty than chronological age. And LH and FSH are expected to rise only after the bone age or the biological age has reached an appropriate point in development. Bone age by itself, either advancement or delay, does not diagnose anything. It's like height and weight and blood pressure. It simply tells me something about the boy. It does, however, indicate the remaining growth potential. Now here is how we determine bone age. These are 2 x-rays of the hand. This is the bone age, or the hand x-ray of a small child. And what you see is all the finger bones, the hand bones, and the wrist. Now you notice that there's a number of small, what appear to be small bones here. That's actually not a separate bone. That bone is part of this bone. This is one structure. What's happening is that the x-ray only can see bone when it's calcified. So not all of this bone has become calcified. There is calcium in this part of the bone, and there's calcium in this little spot here. The rest of this bone that you can sort of imagine in your eye, in your mind, is not calcified. It's only cartilage. And so the x-ray can't see it. That is the only part of the bone that can grow. Once it's calcified, the bone doesn't grow. So only this uncalcified section grows. That's what we call the growth plate. So this x-ray allows me to see the growth plate. It allows me to see how much of these bones has calcified. Here's a growth plate here. There isn't one really here yet. Maybe you can sort of see it. It hasn't developed. Well, it turns out that these growth plates, or these little bones here that we call epiphyses, mature at a very predictable rate. So that by looking at the x-ray of a child and comparing that to a book that someone painstakingly put together that shows me what a typical hand looks like at various ages, I can tell, not just me, but any pediatric endocrinologist can tell the degree of development that has been reached by that child. So here's the bone, the hand x-ray of a child of about 15 to 16. And what you see here is that these bones have been much more developed. And if you look carefully, you can see that we have just a little bit of dark area right there that hasn't quite fused together. Whereas up here, this is completely fused. This is just about fused. There's a little bit of dark area right here that hasn't quite fused. So this is a child who's almost reached full growth potential, almost reached full maturation, and is getting very close. You can see a little bit of open growth plate right there. In another 6 months, a year, this will be completely closed over and you won't see any openings there. So this is what is used by the endocrinologist to determine bone age. And as I said, bone age is the best predictor of the timing of puberty. So we can look at a bone age and say, well, this 11-year-old boy has a bone age of 9. I really wouldn't expect puberty to be starting much yet. So the fact that his LH and FSH haven't elevated doesn't mean anything. I wouldn't expect anything to have happened yet. Whereas, you know, this child has a bone age of 13 or 14, and the LH hasn't gone up yet. That means to me, well, good. Testosterone production is progressing pretty well. The pituitary hasn't yet become experienced lack of suppression. So this is basically all the background we're going to talk about, and now we're going to move into some more sort of patient-oriented clinical aspects of testosterone therapy. Any questions about any of this background?
Give me a second to unmute.
Unmuted.
I've figured out which one of those is feeding back like that. And so, any questions? No questions.
Okay. The in-person group was much rowdier, I have to say. They kept interrupting me. Okay, so now we're going to talk about timing of testosterone therapy, and this is something that I know causes families some degree of anxiety, and hopefully I can at least explain this to you, although I don't think I can necessarily give you enough certainty to get rid of the anxiety, because the answer is that we don't know the right way to do this. So should this be started in early or late childhood? I already showed you that there may be that there is some production of testosterone in that first week or month of life, and you know, should we in fact be giving our kids some testosterone early on in order to mimic that? Would that help with some of the complaints of small penis which occur? Would we see some behavioral benefits in children if they're exposed to the testosterone that they're supposed to receive during this time? To be perfectly honest, no one's actually done a careful study to know if boys with Klinefelters even make testosterone properly during that time. Maybe they do, and this is not really even a concern. Would there be physical benefits of low doses of testosterone in early childhood? What about in later childhood? Maybe we're not very good at testing for testosterone, and we're missing small amounts of testosterone that boys are making later in childhood, and therefore they would benefit. They would benefit from being exposed to some testosterone in later childhood. Give me 1 second here. So this is theoretical based on the low doses that appear to be, or the low concentrations that appear to be present in typical boys.
Dr. Zeittler, I have a couple of questions.
Okay.
I have 2 questions. The first is, does this explain why Klinefelter boys tend to be taller? And that came in more related to the bone age stuff.
Yes, it explains part of it. If there is not sufficient testosterone production sufficiently early or at the appropriate time during puberty, then growth plate maturation won't occur at the proper rate. The growth plates will stay open longer, and you will get taller than expected stature. So you will actually see that kind of tall stature in any circumstance in which testosterone production is not adequate to promote appropriate bone maturation. However, that doesn't actually explain all of the tall stature in Klinefelters, because these boys are actually often tall prior to puberty, and that could not be explained by abnormalities in testosterone production.
The second question is, how are you defining childhood? And the person asks, is it 1 to 10 years?
Childhood for this purpose really means the time up to when puberty begins. So that's going to be somewhat different from boy to boy. Puberty starts earlier in some kids than others, so it's not age-driven. Childhood, from an endocrinologist point of view, is all that time really until puberty starts, and now you enter into the next phase of development. The possibility is that testosterone should be age-driven, so we should start testosterone at the normal time of puberty in boys, 12 to 12 and a half years or so. The problem with that ultimately is not all boys start at the same time. So we might, and not all boys will need testosterone. So we might be treating kids with testosterone who maybe don't need it, or we're starting too early, or we're starting too late. Another approach really is biologically driven. So if we say that the pituitary will start to increase LH production when it wants to, when the kid is ready for puberty to begin, and that if there is not enough testosterone production to satisfy what the pituitary feels should be happening, if you will, then when there is not enough testosterone, LH will begin to rise outside of the range expected for age. This indicates that the pituitary is basically trying to stimulate the testis and failing. And perhaps this is the best sign for initiating testosterone therapy. Another approach is to wait until there's really signs of need for testosterone, and that would be the appearance of breast development in boys. So in other words, really make the kid prove that testosterone production is necessary. Graphically, what we see then is that testosterone is very low in kids. It begins to rise, and we have 4 possible times to initiate testosterone therapy. Early, preemptively, if you will, before there's any evidence for problems. 2, at the first sign of any problem. In other words, we wait for the LH to begin to rise and we watch carefully. Third possibility would be to wait until the LH is elevated and testosterone is truly beginning to fail. What it should do is continue to rise. Testosterone in many of these boys will begin to fall. So maybe we should wait for that point. Or 4, wait until we have clinical signs and symptoms of testosterone deficiency. There are arguments for all of these. I can't say which of these are right or wrong. I can tell you the one that makes the most sense to me, and that is to not treat too early, not treat too late, but to treat at the first signs of problem. This simply makes common sense to me. You begin to watch carefully, and if there's any evidence that the system is beginning to not increase testosterone production, that the LH is beginning to rise inappropriately, the first sign that testosterone production is not adequate, that you then intervene to make sure that the rest of the course progresses appropriately. Don't wait until there's certainly not clinical signs. Don't wait until there's actual failure of the system, but look for early signs of failure of the system. I cannot, however, defend that with any scientific studies that suggest that the outcomes are better when you do it that way. It just makes sense to me. Questions?
There aren't any posed, oh wait, here come some. All right. The first is, if you start testosterone therapy early enough, can you prevent much of the height abnormalities?
Yeah, again, so not all of the tall stature in Klinefelters is due to the testosterone deficiency. There are aspects of tall stature that are related to other genes that are present in excess in boys with Klinefelter syndrome. So you cannot correct all of the tall stature. However, you can certainly prevent those parts of the tall stature that are related to the testosterone deficiency. So you can have an effect on the final height.
Ray, do you have any follow-up to that? Your mic is open. Okay, no. The second question, why give testosterone? A urologist we had a consult with said there was really no reason to start a dependence on it.
Oh my God. You need a new urologist. Excuse me, never mind. I didn't say that. That is extremely, that demonstrates lack of knowledge of Klinefelter syndrome. I can't imagine what somebody means by dependence on testosterone. Part of me wants to go back, to go back to that urologist and ask him how he would feel about not having testosterone. So the reasons for starting testosterone: promotion of normal secondary sexual characteristics and normal normal sexual function. In testosterone deficiency, it will be quite variable. There'll be a big spectrum, but a lot of these boys won't develop appropriate amounts of body hair. We talked about the stature abnormalities. There are abnormalities in body composition, so the sort of big-hipped, sort of feminine body habitus that can occur in testosterone deficiency can be prevented. Erection function, normal sexual performance, shaving, muscle strength, testosterone is important in all of those. Now that doesn't mean that all people with Klinefelters will need testosterone. In some boys with testosterone production is quite good, which is why I don't advocate necessarily just starting it at a certain age. But in those patients who truly have testosterone deficiency, I think it's in their best interest for health as well as normal adult male function to have testosterone replaced.
Valerie, your microphone is open if you want to follow up. Okay, no follow-up. Next question. When looking for risen LH, how can you be sure you're not just seeing a typical spike?
Yeah, it's a very good question. I wonder if somebody's an engineer. You wouldn't respond to a single value. So these spikes are very short. So your chance of actually getting one is relatively small, particularly during the daytime. They're more frequent at night, again, particularly early in puberty. So if you were drawing a random sample during the day and happen to get a spike, what I generally do is I want to see that again on a separate sample, a few weeks or months later to be sure that it's true. And when it's true, you generally see that it's continuing to rise further.
Okay, John, any follow-up to that?
No, that's great, thanks.
All right. Next question. My son at age 14 had an LH of 10.4, FSH of 27. 6 months later, his numbers were FSH 37 and LH 5. we were advised to watch and then check again in 3 months. And to not start testo therapy yet. She did that in 2 questions.
Yeah, I think that's actually reasonable because, as the previous questioner said, there is going to be some pulsatility here. I think it's reasonable if you get one, the second one does not confirm it, to continue to watch. It sounds, however, like your endocrinologist is doing a good job of saying you're going to continue to monitor this, as opposed to, I think the only mistake would be to say, so therefore there's no problem and don't ever look again. But I agree. I think it makes sense to be convinced that testosterone therapy is necessary, and you can do that by continuing to track the pattern.
Okay, Stacy, your mic is open, and Stacy was texting me that I think I read something incorrectly. So Stacy, why don't you ask directly?
Just that it was 0.5, not 5.
Oh, it's 0.5. I would actually repeat that. I'm not sure I believe it. The other thing you have to keep in mind is that that blood tests are never perfect, and if they don't make sense, they should be repeated.
So the fact that it's 0.5, and I've got the 2 reports in front of me, and we just saw his doctor a few weeks ago, so why is the 0.5 a surprise? Because it went so far down in 6 months?
They don't fit together. The 10 and the 0.5 just don't fit together.
Okay.
So one or the other of them is not right. Now, is it that what John did and that you just got incredibly lucky and caught the tip of a spike on that first sample and really there's not much going on yet? Yes, that's possible. So the thing to do is just to wait it out until it clarifies itself. It will eventually become clear.
Thank you.
I think what I'm going to do, because there are still like 3 or 4 questions here, and I'm, serving as interpreter really doesn't make this as efficient as it could be. So next up is Gloria. And Gloria, if you're ready, your microphone is open. Gloria, are you there? Check your muting on your own phone or whatever. All right, Gloria, we can come back to you, but we're not hearing you. So the questions are piling up quickly here. We have Elizabeth Fuller is next. Elizabeth, your mic is open. Elizabeth, are you there? All right, Gloria did not type a question, but I've left Elizabeth's mic open, and her question is low testo or high LH more indicative of the need for testo? How about elevated FSH? So I don't know if that was clear or not.
Yeah, I understand the question. So elevated FSH, as you remember, if you go back to that one of those first slides, I showed you that FSH is mostly related to sperm production. And so the high FSH is a marker that sperm production is poor. It's not telling you really anything about testosterone. So FSH is telling you about sperm production. LH really tells you about testosterone. So which is a better marker of need for testosterone? It depends on how old you are. The problem with using testosterone to determine the need for testosterone in a boy during puberty is all boys increase their testosterone at a different rate. So it's very difficult for me when I see a boy to know what his testosterone should be until he gets to be really adulthood. So if it's 61 visit and the next time I see him it's 90, is that enough or not? But I'm lucky in that I can rely on the pituitary to tell me. If the pituitary the LH starts to rise, what that tells me is his pituitary is not happy. I don't need to make guesses about whether the testosterone is sufficient. If this kid has a persistently elevated LH, then testosterone production is not adequate. I don't need to rely on my judgment. I can rely on his own body's judgment. In the pubertal age group, LH is generally a better marker of the need testosterone because it's more interpretable. In adults, testosterone can be used because it shouldn't fall. It should really, within reason, stay steady once an adult level is reached. So a falling testosterone would be a sign of deficiency. We also have pretty good idea of how much testosterone a male should have. But one thing that does make it a bit murky and that makes LH worth considering is that the range for a normal testosterone in adult males is very broad, 300 to about 1,000. And it's probably true that any one male is meant to be in some narrower range in there, and you have no idea where that's supposed to be. So it may be that for some guys, a testosterone of 400 is what's appropriate, and that they're making their much testosterone as their body expects. Whereas another guy, 400 would be low, and he really should be at 880, and an elevated LH would tell you that. So a guy who has a testosterone of 450 and the LH is normal, then the testosterone production is as expected. Whereas a guy who's got an LH of 400 and the LH is 25, then there's not enough testosterone around. So that is one thing to keep in mind.
Okay, Elizabeth had a couple of follow-ups. So Elizabeth, your mic is open if you're able to speak. All right, no audio from her. So she writes in two additional little blurbs here. I had regular blood levels also, and they were sent to different labs.
Ah, thank you. Go ahead.
Which is why they were different, is her recommendation. So it's not really a question, but maybe you can comment on that.
Yeah, actually, thank you. I lost my train of thought. I actually meant to raise it up. The other thing to keep in mind when we talk about, is testosterone a good marker? Again, all of these things are only as good as the test, right? So it's a number on a page, and because it's a number on a page, people can be sucked into thinking that it has some rigorous meaning, and the reality is that it may not. Testosterone in particular is a tough assay, and testosterone measured in different laboratories may not be measuring the exact same thing. There are what are considered to be very rigorous gold standard testosterone assays that are done in specialty laboratories, but even they are subject to problems. It's different at different times of day. It's affected by all sorts of other things. The testosterone assays that are rapidly done in your local hospital are fraught with problems, and so you need to take any value also with a grain of salt. And as the questioner raised, the levels were done in different laboratories and they got different results. So is that because they were done on different days, that one of the laboratories' assay wasn't working that day, or because they're actually measuring something slightly different? Is hard to tell. The only way you could really know would be to send the exact same sample to the two different laboratories on the same day.
Okay. Valerie has a question. Val, your mic is open. I'll read your question and then you'll be able to follow up if you want. Will testosterone treatment harm any potential for sperm harvesting or reproduction for any reason?
So this is an unknown. There have been a few sperm specialists who've argued that this could be the case. There is no really good evidence in the literature that that's the case. So I don't know why that would be the case. Testosterone, especially locally, is needed for sperm production. That's why sperm appears after testosterone is produced. Is it possible that the Klinefelter Test handles testosterone wrong and makes too much estrogen out of it? Yes. So therefore, is it possible that the sperm is affected by that? But there is no published evidence that that is the case, although there are people who go around saying it's the case.
Okay, Valerie, I'm going to open your mic now. Your connection's a little noisy. Do you have a follow-up to that? Okay, no additional question on that. I have two more questions, one from Gloria, one from Ray. So from Gloria, the question is, how frequently should labs be drawn, LH, FSH, testosterone, and so on? And she follows up with, my son's endocrinologist told me in July that we could start testosterone then or later, in quotation marks. I do not have any lab levels yet.
Well, how often? So what I can only tell you what I do. Again, there's no science here, and no one's studied how to do this and what's the best outcome, and it's probably never going to get done. What I do is I start to look at LH and testosterone really at the first signs of puberty, so that I get a sense of where we're starting. The frequency depends on how quickly puberty is progressing, or if it's a new patient, how far into puberty they're going, but anywhere maybe every 6 months to a year. Not that frequently, because things don't change that fast. So every 6 months to a year. If, like the previous questioner asked, if it's starting to rise and I might want to take another look, I might do it a little sooner, 3 months or something like that. But there's no rush on these things. Puberty takes 4 years in a boy, and so if you look every 6 to 9 months or so, that's perfectly reasonable.
Okay. Gloria, I don't know if you can talk through your mic. All right, no, but the text seems to be working well. We picked up another question, but first is Ray. Ray, I've opened your mic. Can you speak?
Yeah, can you hear me?
Yes.
No?
Yes,
oh, okay.
We can hear you fine.
All right. So, when should you first bring your son into the endocrinologist to start having them look at him for testing? At what age?
What I generally do is well, in our clinic, what generally will happen is that I will see the kid whenever they show up. Okay. At diagnosis, sometime during childhood, if they're being seen for other issues, just to have a discussion about all of the things we're talking about today. And then I generally recommend that people come back and see me 11 and a half to 12 years of age or at the first sign of puberty.
Okay. I have another question.
Go ahead.
Is it ever the case that a Klinefelter boy or man will not need testosterone, or it's just a matter of just getting it started at the right time?
Remember, most men with Klinefelters are diagnosed as adults because of infertility. So, so obviously most men virilize okay. What I can't tell you is definitively whether they were absolutely fine or would have benefited from testosterone. I don't think that's necessarily a knowable question, but we do know that a lot of men with Klinefelters do go through development without anybody noticing any problems.
I guess what I'm asking is if a boy comes in, do you ever have anybody that you don't eventually prescribe testosterone to?
Yeah. Oh, sure. So I'd be making this up, but probably something on the order of 10 to 20%, 30% of the kids sort of seem to go fine for as long as I continue to see them.
Okay. Okay. Right.
All right, I'm going to mute you, Ray. And our next question is from, I think it's Jeannie, and she joined the meeting a little bit late. So just for your context, Dr. Zeittler, does one type of testosterone treatment show greater results over another?
So we're going to get to treatment here in a few minutes.
Okay, and another question that might be something for down the line from Gloria, and that's, is the incidence of testicular cancer, and diabetes really increased in Klinefelters?
You really increased. Well, we'll come back to diabetes. I cannot say that I know the answer about testicular cancer. So I'd have to pass on that question.
Okay, that clears all the questions for now, and
okay. Let's move on. So, so small penis. So, what does this mean? So, sometimes I get asked this question about treatment for small penis in Klinefelter syndrome. So, a normal penis, there's quite a wide range. And a normal penis in an infant is considered to be anything greater than 2.5 centimeters, or about an inch in length, and about 1 centimeter, about a half an inch in diameter. The penis may be small due to inadequate testosterone production in utero or in early childhood, and a short course of low-dose testosterone can be used to promote enlargement of the penis. However, therapy is not required except for cosmetic purposes and won't have any effect on adult penis size outcome one way or the other. So there's no evidence for effect on adult penis size, and if you treat, it may regress and you'll have to repeat the treatment. So sometimes families request treatment just for cosmetic reasons, no questions from the grandma, changing the diaper, whatever, but I would say the minority of families feel a need to go this route. You can use testosterone injections, 25 milligrams once a month for 3 months. There's no negative side effects to doing so. So now gynecomastia, breast development. So just a little information about breast development. This is very simplified, but it's all you really need to know. Estrogens stimulate breast development. Androgens inhibit breast development. And breast development is therefore thought to reflect an increase in the ratio of estrogen to testosterone, either decreased testosterone or increased estrogen, or a change in the rate of conversion from testosterone to estrogen. And I showed you in an early slide that that testosterone is converted to estrogen. As I told you early on, that estrogen is converted to, testosterone is converted to estrogen. So a change in that conversion rate can also lead to a change in that ratio. So if you look at causes of abnormal estrogen to testosterone ratio, what we see is that if testosterone is rising slowly, it fails to keep up with the early estrogen production that occurs in boys. And this failure to keep up testosterone production is characteristic of boys with any kind of testicular abnormality. So testosterone is made, it's converted to estrogen. You get a lot of estrogen around, but the amount of testosterone rising isn't enough to counteract that. So, and furthermore, when LH begins to rise, it promotes estrogen secretion preferentially. Furthermore, production of the hormone androstenedione from the adrenal gland is a good precursor for estrogen. So therefore, the decreased testosterone production early on doesn't balance the increased estrogen, and that's why we see gynecomastia in kids with testicular abnormalities of all kinds. It's not specific for Klinefelter syndrome. Okay, so this is gynecomastia. So other consequences of testosterone deficiency: reduced body hair, decreased muscle mass and strength, increased fat mass, altered fat distribution, more like a female than a male, unfavorable cholesterol changes, decreased hemoglobin, decreased sex drive and erectile dysfunction, low bone density, and mood changes. Benefits: virilization, the outward signs of pubertal development, promotion of normal sexual function and development, maintaining similarity with peers, promoting self-esteem, muscle development and fat distribution, and reduction in the excess limb length that you can see if you don't have appropriate maturation of growth plates. Bone maturation and mineral accumulation, so increased bone density, and prevention or treatment of gynecomastia. And potentially improvement in behavior. In many families report improved stability of mood and other aspects of behavior in kids when they start testosterone. That's never been proven scientifically.
Dr. Zeittler, I'd like to ask a question here that's a little bit oblique, but it does come up in a small minority of our constituents, and that is there a reasonable alternative to testosterone therapy for someone who would elect to not have testosterone therapy? This minority of individuals identifies as intersex, not in the physical sense, but in the emotional sense.
Yes, so this is obviously a topic for another hour's or two's conversation. But estrogen therapy will fill many of these gaps, although not the ones related to manliness, obviously. But in terms of bone development, etc., estrogen would, and promotion of bone maturation and dealing with the height, potential height abnormalities, estrogen can fill that role. And in fact, it's estrogen that is filling that role. It's testosterone being converted to estrogen that's filling that role. Testosterone itself, however, is necessary for the manly functions of testosterone.
Thank you.
Okay. So disadvantages. Acne, that's part of being a teenage boy, but testosterone is responsible. Increased sexual activity. So masturbation, etc., can be a problem depending on the child's behavior and developmental level. Increased strength, again, which could be a downside depending on the behavior. And short stature can occur if it started too early or is titrated too fast. So option for testosterone therapy. So this is a graph that shows what testosterone levels look like in normal men over time. So this is 2200 in the evening, so sort of midnight almost, a little bit before midnight, rises in the morning and then falls over the day. So ideally you would like to imitate that. However, it's difficult to accomplish. The options that are available are oral testosterone. It's really not used extensively in the United States because of concerns for effects on the liver. There may be less concern with modern agents, but there was bad experience with previous agents, and so people remain cautious. It is used in Europe. Injected testosterone, which is an ester of testosterone in oil so that it's slowly released. It's given every 2 to 4 weeks and it's titrated individually. The benefits are that the injections can be supervised so that you know the kid got it. It's very inexpensive and you don't have to fuss with it in between. The disadvantages are that the effect may be inconsistent over the month and that requires an injection. So this is what I mean by inconsistent. So here is testosterone being given every 4 weeks. It goes up, it comes down. It goes up, it comes down. These dotted lines are the sort of normal level testosterone in a male. The more frequently you give it, the less you see of that. And given in a boy, excuse me, I'm sorry, above this is the level you'd like to see, above this line. So you're getting there and falling below, getting there and falling below. Now that has to do a lot with the injectable dose. Here you see less of the decrease in the level. It's rising over time. Give it more frequently, and you can attain a level that remains within the target range throughout the period of time. So you can do it. It works for a lot of guys, but there is this theoretical disadvantage of it rising and falling over the month. My starting dose is about 75 milligrams once a month. Pubertal dose of 150 to 200 milligrams once a month, and you titrate to an adult dose of about 200 milligrams every 2 to 4 weeks. It's titrated to that dose over 3 to 4 years, about every 12 months or so. The adult dose determination, it's very difficult to actually measure a level because it depends what time of the month you're measuring it. Therefore, are you measuring the peak or the lowest value, the trough, and how do you interpret that? There's arguments that go on about that. Personally, I find it most useful to use subjective criteria. Many of the boys are able to tell you when they feel right. They can often describe being too high and being too low, and you can use that subjective information to titrate the frequency and the dose at each injection. There are transdermal versions of testosterone, meaning through the skin. There are patches. They come in multiple strengths, and adult doses vary. They're changed daily. They're more consistent than injections. The problem with them is that the doses are fixed, so less flexibility for titration. And they've not been well received in general in the adolescent population. They're itchy, they fall off, and your friends can see that you're wearing it. So I've not had much success with the patch. I've had more success with the gel. They come as either a fixed dose pack, it's like a little ketchup packet, or in a pump. I have generally used the pump because that gives me more flexibility for dosing at different levels. It's applied daily. Again, it's more consistent than injections theoretically, although there are variability in absorption, and some kids have a harder time finding the proper dose than others. The disadvantages are it requires a daily application. Some of the boys who have problems with textures find it messy and they don't like it. It may require parental assistance, and there is need for attention to prevent transfer of testosterone to others. There are other versions. There's a buccal version that's applied to the lining of the mouth. I have really no experience with it. There are implants that are placed every 3 to 4 months. I have no experience with it. I remain concerned that we don't know enough about them in terms of predicting the dose, because once it's in, you're stuck with that dose. And so I think I wouldn't be the first one to try this on my child until we have a better idea how to pick that dose. There's depot testosterone injected every 3 to 4 months. The delivery is designed to be more consistent than monthly injections. The data look good on this thing. I am unaware of any experience in children, so it may be that we need to wait until the kids are on an adult dose to switch them over to something like this. But I have no personal experience with it.
Is that product available?
That product appears to be available, but I only know that because someone gave me a heads up and I looked it up, and it looks like it's available, but I really don't know much about it.
I got a question from someone in Europe who uses it and was planning to move to the U.S., and he said it's not available here. So
it may not be available, but I've heard either rumors that it is now available or is soon to be available.
Okay, thank you.
Okay, how to monitor testosterone. Again, as I told you, injections is tough. It really, subjective ends up being useful. The reality there is that kids are going to take it as often as they want to, so they're going to take it as frequently as they feel good, so helping them figure out what feels the best is probably the best way to do this. I've not used a lot of blood testing with injections. I just don't know how to really interpret them. Gel is tested as a morning testosterone blood test 1 month after a dose change, once you find a stable dose twice a year for adjustments. So that's it about options for therapy. The bottom line is it's entirely up to the boy, the man, and his family. You can make any of these work. There's not one that's better than the others. They all have their good sides and bad sides. It's different for everybody, so don't let anybody tell you one is better than another. It's just not true. It entirely depends on the kid. Now, it is difficult to dose the gel at the very low doses you need for initiation of puberty. So in kids early in puberty, it's hard to use the gel and not overtreat. That would be the only circumstance in which I would have a preference. Questions? We just have just a few more slides to go.
If you have a question, either raise your hand on the toolbar or chat something in quickly, and I'll open it up. Okay, Gloria has a question. I know that Gloria was the one who asked about diabetes, and
we'll get there.
Okay.
If it's about diabetes, we'll still get there.
All right, and I don't see her text. Gloria, your mic is open, but we've had trouble with your mic. All right, so she is typing, my son has been using 50 milligrams per month since July. Would we, and she's still typing.
Would we?
Yeah, waiting for the second part. I think the text editor has the characteristic of if you hit the enter key, it sends the message rather than just changing lines and stuff. So it says, my son has been using 50 milligrams per month since July. Would we or should we have a blood test done? We see the MD next week.
I wouldn't recommend it. I don't think it'll tell you anything. It's a very, very low dose. I would not expect much to change, and I wouldn't know how to interpret any blood test done on it, and it wouldn't change my approach to therapy. You would need to discuss that with your endocrinologist, though.
Okay, Gloria, well, if you have follow-up to that, I'll watch, and meanwhile we can proceed.
Okay, so many people have questions about whether testosterone helps with behavior, mood, speech, learning, motor skills, and the answer is we really don't know. There's a few studies that are published, and these are in the handout. These are mostly small studies. They do report some improvements in mood, attention, relationships, but really we're talking about a total here of about 35 or 40 kids ever tested. So most of the rest is based on anecdotal evidence. There is a study by Judy Ross at Thomas Jefferson. She treated these kids with low-dose oral androgen called oxandrolone in boys prior to puberty. The study is done. We expect those results sometime next year, and that will be very interesting to see if that's useful. There is a pilot study going on at Children's. Basically, those kids who were started on testosterone replacement therapy for routine clinical reasons were tested for a variety of outcomes. And just briefly, here's just some initial outcomes that Dr. Tartaglia used actually for recently getting funded by the NIH to undertake a full study, and we saw some improvements in externalizing behavior, in other words, acting out, improvements in attention problems, and improvements in personal adjustment. She's now been funded to undertake a full blinded test of that to know. And that will be important because it's very difficult to know for sure about behavior when it's all based on anecdote and the families know the kids getting the injection or the treatment. So the results of this will be really helpful to know if we should in fact be starting to treat kids before physical evidence of testosterone deficiency of any kind in order to try to promote better behavioral and mood outcomes. But we don't have those answers yet. So finally, other hormonal abnormalities in Klinefelter's. Hypothyroidism is more common in kids with Klinefelter syndrome, and just briefly, this is a similar structure. There's a pituitary hormone called TSH that stimulates the thyroid gland to make T3 and T4, which are the thyroid hormone. When there's not enough of that, there is lack of suppression of TSH, and the TSH rises. So this can be very easily diagnosed by an elevation in TSH and can be treated. Whoop, sorry, going the wrong way. This is primary thyroid failure, failure of the gland itself. The cause is unknown. In analogy to testicular failure, as the thyroid fails, the T4 goes down, the TSH rises. Treatment is easy. It's treatment with T4. You don't need to replace T3. The body converts it automatically. And you titrate that until the TSH is normal. So that's actually quite easy to do. Diabetes appears to be increased in Klinefelters. It's generally related to excess body fat and the obesity that's more common in Klinefelters, as well as the decreased fat to muscle ratio. So there's more fat and decreased muscle, so that sugar metabolism is abnormal. That does appear to be increased. It can be avoided with good diet, exercise, and lifestyle management. I have a young man with Klinefelters and diabetes whose diabetes got much better when he was able to get his diet under control and lost about 40 pounds. So the diabetes is related, as it is in most adults, to excess body fat and a sedentary lifestyle. Low bone density has multiple causes in Klinefelters. Vitamin D deficiency can be quite common in general in adolescent populations, particularly in those whose social interactions or athletic abilities lead them to have a sedentary life and not spend much time outside. In addition, having low muscle tone and low muscle mass is bad for your bones, because the bones respond to muscle mass and pull by strengthening. Delayed testosterone replacement or development of testosterone deficiency will also promote low bone density, and therefore testosterone replacement is important. But overt osteoporosis with fracturing is actually very uncommon in Klinefelter syndrome. And we're done. Any more questions?
I'm going to open microphones in hopes that we don't get too much feedback. And I am watching the question panel. One just appeared. Gloria asks, I saw my son's papers talking about intracytoplastic sperm injection, so ICSI.
ICSI, yeah.
Resulting in successful birth. Can you comment on this?
You know, I think it would be better really if you had a chance to ask these questions of reproductive specialists. I can only tell you sort of the Reader's Digest version, and that is that success with ICSI is increasing nicely. And that there are increasing number of successful births from ICSI. But to be honest, I know rather little about the details of sort of reproductive endocrinology.
We do have several presenters from past conferences that one of them is likely to do a webinar on this subject. But I will add that this subject is one that has been very controversial, because the dynamics of this field are in flux, and there are a lot of theories about how things work, and there's not a lot of agreement. There was kind of a dust-up at the last conference because
interesting.
several endocrinologists who were talking on this and urologists were in some disagreement about this. I have another question from Jeannie, and it is, I may have missed this topic, but at what age should the boys seek therapy?
That's what the last hour and a half's been about.
Right.
I would recommend consultation with an endocrinologist at the latest between 11 and 12 years of age, or at the first sign of puberty. Some people choose to meet with an endocrinologist earlier than that.
Okay, I want to remind everyone that especially those who arrived a little bit late or had some struggles, that this session was recorded, and assuming that all the technology worked the way it's supposed to, in a couple of days we'll have this posted on the website, and you'll be able to view it as many times as you wish. You won't have the benefit of open-ended questioning, but you'll be able to go through this over and over again. I have one question, and I apologize if I missed this discussion, but you use the word titrate, and I'm not sure that we have a definition of exactly what titrate means.
Fair enough. And titrate just, that's jargon. That just means raise the dose and use some sort of outcome to decide whether you need to continue to raise it. So it's really just dose changing.
Okay. All mics are open. Does anyone else have questions? Okay, hearing none, I really want to thank you, Dr. Zeittler. This was outstanding, very clear, and very easy to digest. So I thank you very much, and it's no wonder that you received rave reviews from conference attendees. The comments about your presentation were the best of the bunch.
Oh, my pleasure. Thank you.
And Gloria would like to contact the clinic to arrange a visit with you, and I presume the rest of the clinic staff, and I will help her make that connection.
That would be great. Yeah, she can contact Susan.
Okay. I believe that's the end of our session, and I thank you all for attending, and watch for the announcement about the recording being available soon.